This is the Limb Lengthening and Reconstruction Society podcast, Distractions, exploring the science, innovation, and people transforming limb deformity and reconstruction. LLRS is thankful for its podcast industry partners, Diamond Level Orthopediatrics, Sapphire Level Orthofix, and Garnet Level Smith & Nephew. In this episode, Dr. David Frumberg welcomes his guests, Drs. John Scolaro, Edward Westrick, Mitchell Bernstein, and Geoffrey Marecek, as they discuss the treatment of bone defects.
Welcome, everybody, to this next episode of Distractions, the official podcast of the Limb Lengthening Reconstruction Society. We have four totally awesome guests today. The Harborview Trauma class of 2013, literally four of the four. It's insane. I am not going to introduce everybody. I want everybody to introduce themselves, starting with Eeny, Money, Money, Mo, John Scolaro.
Awesome, Dave. Thanks for having us. John Scolaro, traumatologist at the University of California, Irvine. As mentioned, Harborview for fellowship, and I've been at UCI in Southern California now for, I guess, 13 years.
And just going clockwise, we have Ed.
Eddie Westrick. I'm at Allegheny General Hospital in Pittsburgh. I did my med school and residency at University of Pittsburgh, then spent my fellowship at Harborview with these guys, and have been back in Pittsburgh since.
And then I got Mitchell going around.
Mitch Bernstein in Montreal, Canada. Trained in McGill in Montreal, and then did a trauma fellowship with these wonderful, wonderful humans. And did an extra year training in limb lengthening, and now I'm back in Montreal after spending 3 years in Chicago.
Last but not least, the man from LA.
Mitch, you forgot that you're the president of the Limb Lengthening Reconstruction
President of Limb
Society.
Lengthening Society. I mean, I don't want to. I mean, we're all equals tonight, Dave. No, so I didn't want to mention that. But yeah,
I'm Geoffrey Marecek. I work at Cedars-Sinai in Los Angeles. Did my training in Chicago at Northwestern, and have been in LA for my practice.
Love that. It's pretty crazy that, you know, this like one class of fellowship, you guys are all fantastic bone defect reconstructors. So we're going to try to get into it a little bit about bone defects, which we're finding more and more it's really quite a huge challenge in orthopedics. And I'm curious, and I don't know, we didn't really rehearse this or anything. I'm just going to kind of like cold call people, but please interrupt because there is no textbook for bone defects. This is all what you like to do. So again, whether it's trauma, infection, tumors, non-unions, revision surgery, we want to break down how we think about bone defects, how we manage them. Okay, so we want to look at principles because there's really no dogma, and we want to talk about maybe indications in some of your decision making. So let's first define the problem. I guess, I'll start with Jeff. Like, how do you define a bone defect?
I mean, just when there's a piece of bone missing. I don't know. I don't.
Nice.
I think that part is simple. The hard part is that I think, you know, they're definitely different. Like a full segmental defect is very different than, you know, having a third of the cortex missing for 5 centimeters, even though they both may be problematic. And, you know, I think part of the reason why there's maybe not much intelligent to talk about that difference is because we haven't really like done a great job of classifying those or really digging into it, really focus on segmental defects, but we don't talk about the others very much.
Meaning like partial defects.
Yeah.
Or articular defects, things like that.
Jeff,
Yeah.
I think one of the things that, you know, that kind of resonated with me when we started to try to, you know, think about what bone defects are, you know, or, you know, solutions for them, or, you know, areas that just aren't going to heal without some other sort of intervention, right? Some other next intervention, next step, something that's not going to heal spontaneously. And so, you know, and maybe some of those bone defects are, you know, how that changes how we approach, you know, the problem. But I don't know, that definition seems to resonate with me, and it also seems to kind of make sense when I, you know, talk to my residents and trainees about it.
I think the animal studies that show spontaneous healing, it's like over 5 millimeters or something like that. Something absurd. Like a bone defect should be something great. I think it's actually even more. I
Well,
don't remember off
animal
the top
studies
of
are
my
tough though, right, Dave? Because that's, I mean, a lot of those, even except for like some of the large animal studies, like none of those things really translate, I don't think,
Yeah.
size wise, right, to the human. And a bone defect a bone defect in the femur may spontaneously heal over a period of time, whereas a similar or even smaller defect in the tibia may persist, you know,
Yep.
forever.
I'm definitely a lot more aggressive in the tibia than in the distal femur. I mean, I think we all of us who do late reconstruction, trauma reconstruction, I think we're sensitized to very minimal critical bone defects, like in the Peloton zone 3, like the bottom end of zone 3, critical bone defects. But in a femur, like I've seen some ballistic distal femurs when I used to work in Chicago that like spontaneously the medial cortex just like bridges. So I think the location matters.
I think you
For sure.
touched on it also, Mitch. Is this acute? Is this subacute or chronic? And then I think you can't necessarily talk about those without the soft tissue coverage, and it's a bone defect talk. But if it's acute with no soft tissue coverage, needs a flap versus not. If it's a subacute or chronic, is it infected? I think all those things are important when we think about it. And I think maybe the three of us all really learned it from you. The way you break down a problem list when you're tackling each patient, I think is really helpful as you go through these case by case.
Dave, how much off the script can we go? Like, can we discuss beards like Ed Westrick versus Jeff Marecek? We go like, are we doing that or no? We're sticking to
So
science.
whether you like it or not, you're the president of this society. You decide.
But
You make the
you're in
decision.
charge of the podcast. Okay, go on with the podcast. Keep going.
All right. We will have a whole subsection on beards and neards at the end of the podcast.
Okay.
All right. What are you guys thinking about patient host factors? Now you can't really change, you can't choose your patients per se, but do you think that plays into anything? Do you think having someone who's like a bad diabetic with a big bone defect, maybe relatively good soft tissues? Let's
I
throw that
think
case out there.
I think like I'll let Ed talk because Ed just spoke in New York at Limb Deformity Conference, and I think he's got into 3D non-biologic reconstructions because of some of his patients that have pushed him that way. Ed, I'll maybe let you. That was more of an intro, maybe to get you into how you've dealt with some of those patients who are not going to tolerate a 12-month, you know, bone transport.
Yeah, I think I don't know if it's, I think, getting into that discussion as far as who is a good candidate for that, I mean, I think it depends on the patient and the discussion that you have with them. I've been surprised in both directions. People I thought would not tolerate bone transport, on initial discussion, and then turns out they have the social network and the wherewithal, and are able to do it. I think just focusing on the host factors, I mean, diabetes specifically, I think the numbers that we're seeing with people are becoming higher and higher and higher. And I think it's becoming a ever increasing problem. I have somebody currently that I'm taking care of with a hemoglobin A1C over 16. I mean, I
Oof.
think some of these numbers are truly shocking. And I don't think it matters what we do in that patient. I mean, I think the risk of complication is 100%. And so I think, as far as the way to deal with those bone defects, I mean, I think those are, when the patient's physiology is that extreme and they're that poor of a host, I mean, I think that's somebody from the get-go, maybe steering towards amputation, to take this discussion in that direction.
16%, that might be the high. I don't think I've seen higher than that. Is it
Yeah.
possible to be like alive with
There,
16% of your hemoglobin to be glycosylated? All right.
it's
Your
not
A1C is like a Slurpee at that point. It's like a
more like
it's like a pixie stick.
yeah, more
Okay,
like
so I think just a little bit more before we start getting into the various techniques we have for management of bone defects is you touched on amputation. It's probably worth talking about, right? So I don't know, Jeff, you want to jump in on this one? Been awful quiet over there.
Yeah, I mean, I don't know. I think probably most of us think that amputation is a viable form of limb reconstruction. Um, and I talk about it with every single patient and tell them, I'd be a bad doctor if I didn't offer you amputation. Um, some people have like kind of cried and hugged me because like nobody has told them they could have an amputation for the last like 3 or 4 years. And then other people have told me they're going to shoot me because they don't want an amputation, and why do I have to talk about it? So sometimes it goes over well, sometimes it doesn't. But like, everything that we're about to talk about is a long process. And if you just want an off ramp to get back to life, people can do very well, particularly with transtibial amputations, and just move on, get past it. So I think you have to bring it up. You don't have to do it, and I think part of that evaluation process of, like we talked about, where is the defect, what is it, right? Like a mid diaphyseal tibia defect is going to be radically different than something that's down missing the plafond, right, or something with a bad hindfoot injury, in terms of how aggressively you push for that. But I think everybody has to consider it, or at least know that it's an option.
So I saw this woman in clinic literally last week, and she has a defect. It's going to end up after she has infection. After all is said and done, it's be 12 centimeters, but her residual, it's more like proximal diaphysis in the tibia, and her residual tibia will be 30 millimeters, and she wants an amputation. She doesn't want to do the whole reconstruction. What do you do with that? Like a 30 millimeter proximal tibia, do you push her toward reconstruction or do you oblige?
Get
What would you say?
get creative. Stick the distal intact tibia up on the, just close down the defect and shape the soft tissues around it, or
So cool.
get wild.
I have a patient.
Yeah,
I've got
I think one of the things that's worth mentioning, right, is that a defect in the tibia and conversion to amputation is a different conversation than a defect in the femur and a discussion about amputation, right? Like the transtibial versus the transfemoral is obviously two very different endpoints for a patient, especially a patient who may be older and have less, physiologic reserve. And then I think the other thing that I think about too with regard to defects is it a, is it an extra articular, is it a diaphyseal defect, or does it involve some sort of the articular, you know, surface either distally down by the ankle or similar? And, is there an arthritic, adjacent arthritic joint? I mean, I think there's a lot of things that kind of go into that because, as we mentioned, I mean, I think an amputation, straightforward transtibial amputation with enough of a residual proximal tibia is a very different animal than the patient that you saw, you know, in clinic, which, I mean, I've seen some, awesome cases about residual tibial lengthening to allow for a more viable, you know, residual limb in the tibia, but that similarly is not for everyone, right? And so yeah, I think that's the thing that makes this like such an amazing conversation is that there's so many different pathways and routes that you can take with a lot of these different patients.
Okay. That's a good set. The stage is set. So I think maybe we move on to a couple of the different options. And
Can I
we'll
add
do,
one point though, Dave?
of
And we
course.
discussed this before. Like I think all of us are interested, and especially the listeners, the 12 people that are going to listen to this podcast, the 6 people that are going to listen to this podcast. Um,
My mom's definitely
we
gonna
have no
listen.
evidence. Our evidence on reconstruction algorithms, I would say, is pretty poor. I'm not going to say embarrassing, but they're all expert opinions. I mean, we really don't know evidence based what's the best for a specific patient. That was my
And with
comment.
that said, we're going to give you all the evidence you need right now in the next 20 minutes. All right. I have some just strategies, and I think this would work best if you guys just volunteer to take them. So there are a couple of different ways classically that we could treat bone defects, one of which would be like if someone breaks a bone and you take that piece of bone and you put it back in, right? That's like one way to treat it. We don't usually do that, but you could imagine a situation with a little kid or something. You clean off the bone, dunk it in betadine or something like that, and you put it back in. I don't know. We're not going to talk about that. We're going to talk
We
about,
still do it for the talus.
oh yeah, well, yeah, works great every time. So aside from that, I was also thinking about this case when I was a second year resident and I dropped an ACL graft on the floor. So you could put that back in too. So, there's chance for everybody. May or may not have happened. All right, we're going to start off with just bone grafting. So I guess the question is, what situations would you be bone grafting? And is it ever enough? And does it work? And this could be straight up bone graft versus Masquelet technique or any kind of graft. I'm saying like non-vascularized grafting.
I just did a
Mitchell.
case last week, distal tibia, plafond intact, acute trauma, 85 millimeter defect, long spikes, long spikes. And I used RIA and iliac crest, still needed more volume, so used a little allograft. So I like bone grafting for massive defects. If either there was never an infection, I think that's ideal. Distal femur is a good one. And in the tibia, I'll do it acutely, sort of like along what Jeff was talking about. If there's an acute, let's say, open tibia fracture, IM nail, cement spacer, it's a critical defect, and then I'll come back 6 weeks later and bone graft. I think those are good scenarios for me. No infection, no history of infection, clean. I like that scenario.
What about, let's say, tumor reconstruction? Anyone doing that? Ed? No?
No, no.
I was just thinking more like no history of infection. You're just taking something out. You have a defect now. Could you just graft it? Because there are products like graft cages and things like that. And Ed knows a lot about that stuff. But so grafting alone, critical defect, let's say 2 centimeter defect in the tibia. Could you graft that? Or Mitch, you do that stage situation?
I don't do acute bone grafting in open fractures or acute trauma. I don't know
Yep.
if my colleagues do that.
Nope.
I do not.
No,
Okay.
nothing acute, but that's I mean, a defect like that, I think is very, especially the younger the patient, the healthier the patient, the more likely I am to think about a masculate type procedure, and then I think Mitch had mentioned it before, but the ones that I think about acute grafting are doing some sort of masculator, especially when there's maybe good viable bone on an opposite surface, maybe a medial or a posterior, you know, uh, cortex that's still intact. So I don't want to remove good bone that's already there that may have the potential to heal with just a little bit of a
Little push.
push. Yeah, I mean
But also,
that's a good.
John, you're basically, again, going back to Jeff, you're taking Jeff's definition of a critical defect and you're forcing yourself to acknowledge that acutely. So it's a smallish defect, 2 centimeters. You're calling it critical, and then you're putting in the cement spacer, as opposed to I am nail, cross the fingers move.
Yes.
I
The
don't
other
know.
scenario
Are
that
my
was
colleagues doing the cross the finger move? Like, are you, Ed or Jeff? Are
it's
you going to do that? Cross the
I'm
finger
I'm, be,
move?
I'm becoming more aggressive with just cement spacers. I mean, I think earlier in my career, I might have done that, but um, not anymore. What is the? Maybe I'll let Jeff answer and then come back to my next comment.
Yeah, I mean, I, I don't know. Like John said, in kids and young people, I'll leave alone. But I like a very low threshold to put in some sort of spacer or space occupying device to try to make a potential space for future graft. Because if they heal on those, like John said, the opposite side is good. So 50% of the bone heals and 50% doesn't, but they don't hurt. You don't have to come back. You don't have to take that spacer out. You can leave it in there. So I'd rather have a unused spacer in there than have them be missing a chunk of bone and now I need to make space for graft and
I've
and
been
they're not happy.
Yeah, I've been, the fingers crossed thing early on, dissatisfied with that. The cement spacer, Mascale for a small defect, just at 2 centimeter defect. Um, I've become more and more dissatisfied with that as well in the tibia, and just open it to the group. Like what has been your experience with Mascale in this situation in the tibia, and what is your limit? What centimeter defect?
I've not had good success in the tibia. And I don't know that it's a size issue. I think a lot of it is the location. And, on one hand, yeah, 2 centimeters is just 2 centimeters. But on the other hand, like if you use, let's say, a medullary based transport device, how quickly is that 2 centimeter transport going to be over? Right. So it's not like that big of a surgery either way, or the amount of work going into it isn't very different. Maybe some of the weight bearing and recovery is, but like I don't know that it's really the size as much as, like we said, who the patient is, what their comorbidities are,
That's
what
where
the
I would like to
situation
see
was.
that's where I would like to see our profession go, is the efficiency of care. How quickly can we get these patients out of the hospital, out of like our clinical practices and back to the life. And that's where I've been inspired with Ed's like 3D stuff. He has a large experience with that. He's getting people just like back to work. They're like, dude, I gotta get back to work. I don't have time to hang out with you, for
Well,
like
but
a
I think
year or
on
two.
a similar line of thinking, though. I mean, I think just say it. Yeah, I agree with Jeff, and so good. That makes me feel better. We've never had that specific discussion, but I think I've been more aggressive about just going, 2 centimeter defect, a small defect, just going straight, Mascale, straight to a bone transport, because I think in the end, there's a lot of these people who are in bone graft and then just been dissatisfied with that. And then you take it to the next step, then the next step. And in the end, you take a step back. By the time you get these patients to heal, they've been through umpteen surgeries, done everything right, done everything that you all would have done, and it's just not working. Versus, I can do one surgery and a quick transport that doesn't take that long, and might seem like it's a more aggressive surgery, but in the end, it saved them a ton of time.
It's
So
literally what plastic surgeons did when they stopped calling it the soft tissue elevate escalator and they called it the soft tissue elevator. They said like don't start with all this rotation flaps and stuff when you just know you're going to need a free flap, just get it
yeah,
over with, move on with your life. So very
Yeah.
similar.
I will say though, Ed, like I think in many ways the first step is the same, right? Because if I have, let's say, a 3 centimeter defect in the mid tibia, I'm I'm still gonna put in a nail, put in a really good cement spacer, and then sit and talk to the patient. If I'm going to do medullary transport, take time to order things, whatever. There's
yeah,
good evidence that transport through a membrane does better. So, I have a membrane, whether I'm going to transport through it or whether I'm going to graft it. And so at that point, all options are open. The patient can be walking, they can do whatever. And then you can, yeah, I'm ready to go to transport, but at least it's just like puts a stop. There's no more urgency. They're walking, they're doing everything. And let's think about it.
yeah, 100%. Sorry if I misspoke on that, but agree completely with what you said. The first
No,
step
you,
is
you didn't. I'm just, yeah,
yeah.
like Mitch said, for the 7 people who are listening,
So if any
stage
of those
one's the
seven
same.
people are early career or learners, what locations in the tibia and the femur would be like real trouble areas? What are the areas where you think you have to be more aggressive?
I mean, distal tibia is probably the obvious one. I mean, I think,
Mhm.
from a masculine or induced membrane standpoint, I mean, Mitch just mentioned the case that he did, but I don't know. My experience in the distal tibia is probably similar to everyone else's on this call with regard to, needing, multiple passes at a bone graft or interventions to get something to heal. Um, Yeah, I mean, distal femur is, in terms of, I mean, most of the defects that we see in the distal femur or in the femur are distal femur defects. We don't see a lot of, large, proximal diaphyseal or like subtrochanteric defects. It's just from a soft tissue standpoint and, uh, trauma, standpoint. But I don't know. I think I agree with what everyone said. I think the first, like Jeff said, the first stages, the first couple steps are all almost always the same, regardless of what you do. And then
Those
after
are
that,
critical steps.
yeah, and you have to figure out, like, is your patient a viable patient for an intervention that's going to require constant attention to detail, right? Like, can that patient on a daily basis, you know, intervene unless they have one of the automated, external frame systems? I mean, can the patient, maintain attention to their care? And if not, then you're down a different path.
So just before we move on, what's the question that everybody always asks about Masquerade is what's your timing between the stages? What do you do, Jeff
Um,
or Mitch, whatever?
I came in hot here. Okay, go ahead, Jeff.
I try to wait longer. I know that, we now have not just rat evidence, but human evidence that the membrane is optimal between 6 and 8 weeks or whatever. But I think Tetsworth clearly showed that it stays viable for a really long time. And what nobody talks about besides the growth factors is just what it's actually like. So when I would come in hot and go back at 6 weeks, it was just like wet toilet paper. It's hard to sew back together. Like, wasn't a real membrane. When I waited longer, you actually have something that you can incise and you can sew back up. So I'd rather wait, closer to, 10 weeks, somewhere in there if I can, 8 to 12 weeks.
I think
You
it's
also have
6 to
to
8
see
weeks.
the like if it's a 3B lesion, like the flap edge, and at 6 weeks I've been burned with going in, and then the flap edge is not sealed nicely, and then there's some leaking, and then there's nice evidence recently with that. Those masculae are gonna fail universally with any history of infection or leaking wounds. So I agree with Jeff.
There you go. All right, the next obvious thing to treat a defect would be to eliminate the defect in the form of a shortening, so acute shortening. And then the question that everybody always asks is how much can you do? And I like to think it's more of a case to case thing, but anyone have any numbers in their head? So let's say humerus, let's say you're doing like a distal humerus fracture and it's dusted. Can you just shorten a defect away there? Compare that to a distal tibia and a distal femur. Anyone have any numbers?
I think the real number is when they lose pulses.
Yeah, that's
Um,
a bad thing.
I don't know. I mean, I think, again, it's all patient dependent, right? Because you get a massive reduction in like tricep force if you shorten the humerus more than 2 centimeters,
Mhm.
but you certainly can shorten it more than 2 centimeters if you know grandma might much rather have a weak arm than be going through a mascale like 7 times. So um,
We have it.
and you can make up length. So I don't know, do
We have an
shortening and then lengthening if you have to.
Sorry, Jeff. We have an epidemic of arms in Western PA that are as wide as they are long, and I don't think they notice the difference when they're shorter. And my one of my partners is notorious. I mean, he'll shorten people. I mean, that's their expectation going into it, that for their non-union, that's what he's going to do, and that's the best option. And uh, I think cosmetically, they don't really notice a difference. It doesn't affect their gait. Nobody really notices it. But I think that's, patient dependent. I mean, I think those are maybe older patients less concerned with their cosmesis, and that may be, totally different in a young patient, a high level athlete, things like that. So I think it's a matter of, in these situations where we buy a little bit of time to know the patient and their goals and wishes. But I think it'd be much better tolerated definitively in the upper extremity than the tibia.
Let's talk about everyone's current favorite thing to do that is not ed, which is more distraction-based treatments. So, Jeff, you want to talk about transport, internal, external, what it is, how it works?
I want to hear from John.
John is what I meant to say.
I would say though, I'll let John talk in a second. Ed Westrick is probably one of the busiest trauma surgeons in the country. So although he has a lot of experience in 3D, non-biologic implants. He also has a significant experience with biologic bone transport. I mean, let's hear from John and then Ed.
And I'm just gonna tee you up here, buddy.
No, we want to hear you talk. Don't.
I don't think so. No, I don't know. I mean, I think I have found that patients um, want to have the ability to do a transport with an internal device. And so I think I have, when my patients who I'm doing either a plate assisted bone segment transport or an internal lengthening, or transport or similar with a medullary device, they like that much better than many of my patients who I have placed frames on. So I think the principles are the same, but I'm trying in a lot of instances to identify whether I can use some sort of all internal technique to do distraction osteogenesis. I just from an infection standpoint, from a maintenance standpoint, I think it's just you know seems to be more in favor recently in my practice.
I agree with that. I mean, I think I mean, full disclosure, I'm completely biased. My career has gone in a direction where I'm trying to do everything possible to find some sort of all internal solution, whatever it may be. And so I'm certain that has an effect on the patients and what they choose. Just in the past with the frames, the awesome cases, and I just feel like it was you know, cases that I love to do and love to teach, and the patients I just didn't felt the same way. And Mitch, same thing you go through, and you guys Northeast, not the California guys, but like in the middle of winter here, dealing with patients with the frames and everything that goes along with it. And it just became a burden for my office staff and my PA. And these are just all things that I was having to deal with and just kind of led me to find other ways, whatever the way. So I think,
Tell us about those ways.
well, I mean, I think like, bone transport with a nail plate assisted, um, um, the 3D printed implants. I mean, that came about. I mean, that was something I was doing like completely in another space, just with foot and ankle reconstruction. Patients that had failed total ankles, failed fusions, just chronic deformity of the hind foot, and those are just cases that you know I I, I picked up on some of that stuff from Dr. Benershka in fellowship, and continued that in my practice, and just found some alternative ways to deal with those problems in that space. And then, I've mentioned it before, but just completely out of this desperation, maybe in patients that weren't a candidate for any other sort of large bone defect. Specifically, it started with the femur, distal femur, where I just didn't have any options other than amputation in patients that were a poor host, poor physiologic host, poor social host, just not good candidates for anything, neither from patient factors or my interest in trying to talk them into some of those things or deal with it, knowing it would be a failure. And so that kind of led me to just make a leap out of desperation from using some of these technologies in hindfoot, or I also do a lot of revision arthroplasty and that kind of thing. So I was using it in these two spaces and took it to a large bone defect of a femur, and it just happened to be the worst of the worst host, and he actually did extraordinarily well. And so I kind of started with the worst possible scenario and patient and went backwards from there, and just it became a tool in the toolbox that I've had some good successes with, and fortunately, just with good patient selection, no major failures so far.
Just good patient selection of the worst patients.
Pretty much.
Are you using bone replacement implants in younger, better hosts?
I have a couple. Um, Um, I I brought some stuff. Um,
Oh, this sucks
You
for the
brought stuff
podcast
to show the
listeners.
camera? Show
Here,
it.
You
bring
guys,
Wow. Oh my
any
God.
any
You
recording
really
listening on Spotify, you need to get on that YouTube right now.
yeah, right. It's just our moms that are on here, so
Yes,
we could
look at
just show
that.
them. Mitchell, nice.
Nice.
Um,
Good.
but I mean, to answer your question, so this is a femur implant. This is a distal femur. I don't have the model to go with it. But cases, this was the first patient, but something similar to this. I've had some young patients, somebody from the middle of the state that was referred to me for amputation. You know, she had been through 3 or 4 surgeries total. You know, the majority of those were non-union surgeries that had failed, and chronic pain, deformity, limb length discrepancy, and I just in 20 something year old patient had a hard time, talking to them about amputation when there was no infection, no soft tissue defect, and you know. They were willing to undergo one more surgery if I could assure them they'd be weight bearing as tolerated immediately. And so I've done it in younger patients, but it's not my first line by any means for a young patient, but it's also not just for old people. It depends on the case. I mean, it's a case by case thing. And just like, we meet these patients at their worst and we go through our algorithm and, every possible option. It's just another option that's there and is available. For some people, it ends up being the best, or it ends up being their preference. There's some people where, um, I don't know, maybe I think it goes back to what Jeff said before. I'm kind of doing everything the same early on. And I think doing good initial surgeries sets you up for having all these as an option. And so I think it's just another tool.
Love that. We're gonna flip a little bit now to try to get some hot takes here. So I'm just gonna call on y'all. So Mitch, first one is the most underutilized technique in bone defect management.
underutilized technique. Underutilized.
Yeah, there is no right
Um,
answer.
I don't know. I think an underutilized technique is acute cement spacer and then a 6 to 12 week later mascale. I think that's underutilized because I think people are potentially a little anxious to designate it as a critical bone defect and then potentially hope it's going to work and or think it needs to be referred on, especially if you're not like working at a level 1 trauma center, with a trauma fellow and 3 chief residents. I think that's underutilized.
You mean for like a relatively small
Yeah, like a
defect
3A,
size
three
wise,
B
but
open tibia
yep.
with 2.5 centimeter oblique diaphyseal defect. There's gonna be a nail in there. And it's like there's a gap, right? It's like one of those sprint trial conclusions. There's a fracture gap. It's gonna go on to non-union, but you did what you think you're supposed to do with the IM nail. It's not infected, and then you're gonna just wait to pass it off and refer it on to, Ed or John or Jeff or you at Yale. You know what I mean? So I think that's underutilized. How's
Okay.
that? Is that a good answer?
That is, I think it's a good answer. It's just funny because, like, if you go to Europe, everybody masculates everything, and they would say this guy needs to leave
Well,
Canada and
I
just
think it
travel around.
matters where these patients. I mean, we've repeated this over and over. Your first surgery and the way you set these patients up leads you to having all these options open. So it depends on the referral pattern and where these patients are going. Which hospital are they going to and who's treating them? If someone on call who doesn't do a lot of trauma, may not be comfortable with putting in a cement
Just
spacer.
throw. Yeah, that makes
It's
sense.
like,
I
don't
like
ask
the
me to
answer.
do an ACL.
Just put a spacer in, pass it off to a sports guy.
Yeah.
Uh, well, I was going to ask what the biggest mistake that surgeons make is. So aside from not putting in a spacer, John, you got anything else? Any other pearl there? Biggest
Yeah,
mistake surgeons make.
yeah, I think people become conservative with their initial debridement because they're concerned about creating a larger defect, and the problem which follows then is that you end up dealing with not only a unhealed area of bone, but potentially also introducing infection because the initial debridement was not aggressive. It wasn't appropriate. Uh, it cut corners. Whereas I think if you ask anyone on this phone call, and I think a lot of us as our practices have developed, when you become more comfortable in the management, utilizing different techniques, I think we're much more likely to um, do a more aggressive debridement because we know we can solve a bone defect in a handful of different ways. We have a couple of different techniques to be able to do that. So I think yeah, the debridement's the biggest shortcoming for sure.
All right, so I already know what Ed would say for this, but Jeff, I want to get your take on this. What's one thing in bone defects that you've changed your mind about in the last 5 years? And you're on mute, which may be by design.
That's what have I changed my mind about?
We should have prepped with questions, I think.
I think
Yeah.
it's better this way.
I don't know. I would say probably the biggest. I don't know that I've changed my mind about it, but the biggest change in what patients are getting in my clinic is probably the advent of balanced cable transport.
Hmm.
And there's still masculine patients, there's still patients with 3D spacers, et cetera. But I think doing that has, balanced cable transport has democratized things a little bit. It's made it a little bit easier on patients. And so I definitely feel much more comfortable offering frames. Like Ed said, I think medullary based things that are internal are ideal, but it's all a balance, time versus, space, of the device, et cetera. And so, yeah, I would say that's opened up a lot of doors for options for patients.
Jeff, are you using any of the automated frame technology in your bone defect management, or is that mostly in deformity? Because that's one of the other things that, I mean, that's probably have more experience with in that than, some of the rest of us. So I'm just kind of I'm curious about that actually.
Yeah, no, I mean that's worked pretty well. I think whether you do more conventional transport, you can drive it that way, and it works very well. And I think it can work quite well for balanced cable transport. And I think, like we wrote up doing one, and then like the Emory guys and Steve Wallace have like come up with so many different ways to make it much more efficient and elegant than sort of the rudimentary kind of first round things that were done. So I think there's lots of good options for doing that. I think it's very promising. That it's definitely still kind of, you're putting a little bit of a round peg in a square hole, because that's definitely not what it was designed for. And I think if there were dedicated design things, it would really be incredible, but it works very well.
All right, I'm going to ask Ed a question. The rest of you guys, this is your warning. To finish it off, I'm going to ask each of you for like a pearl, but it's not going to be something about like having a really good debridement. Okay. I want you to think of something. Mitchell, you've been warned. We could edit this out, or we could let people know. Maybe we
No
edit it
editing.
out.
We don't edit. This is live.
We don't edit. It's
No
raw.
editing. It's
All right,
raw.
here we go. Okay.
It's like a DICOM file.
Okay, Ed, I want to know, where is the field of bone defect management going? So if you had to look to the future, let's say 15 years from now, what are we doing to people? Are we doing transports? Are we doing all this stuff? Are we replacing bones? Do we have biological solutions? Where do you think we're heading?
I think we're still doing all these same things, hopefully advancing the field. I don't think any one of these technologies is gonna make the others obsolete. I mean, I think every patient's different. I think every surgeon's preference is different. The defect, the soft tissues, the acute, chronic, infected, non-infected. So I think fortunately for us that are interested in this space, I think we're still going to have a lot of options. But I think Yeah, I don't know. I think it'll be really interesting.
Yeah. I mean, just being able to gain stability and treat the biology in general as a theme has just looked so different over time. But you're right. The same things just keep kicking around. It's the same machine that we're trying to fix, right?
But I think to your point earlier, I think we are moving more like the elevator rather than the ladder. And I think it's definitely moving in that direction. And patients don't want to lose 2 years of their life, if we can do it in, 6 months.
Yep. Okay. Jeff, you're up first. In closing here, I just want everyone to maybe give one pearl for managing bone defects. I can start with someone else.
I would say no. I would say um, to take your time.
Take your
Uh,
time.
and I mean that in every sense. Take your time planning it. Probably the two biggest areas are number one, take your time talking to the patient. Um, they've really got to know what they're getting into, and you have to really understand them. And then I think, particularly with bone transport, you know, low and like barbecue, like low and slow is the way to go. Right? You don't want to just go rip roaring, you know, millimeter and a half a day. You want to go nice and slow and speed up if you can, rather than coming hot out of the gate.
Yeah, and really go slow through your learning curve as well, right? Take the time to reflect. John, what do you think?
Yeah, I think I would just say that there's a lot of different techniques, but they're all based on a similar set of principles, right? And so, regardless of the actual technical um, surgery that you perform, it's all based on the same set of principles in terms of, stability, care of the soft tissues, avoidance of infection, and as Jeff mentioned, I mean, if we're talking about distraction osteogenesis, low energy, go slow, consistent, and I think Dave, you mentioned a great point, and this is something that, yeah, this is not something that I went through fellowship learning a lot about. So the first cases you pick, like pick straightforward cases, pick, good hosts, uncomplicated defects, if you can. And that's, and then I guess the last thing I'd just say is, this is a couple of, utilize the peer support network out there that exists. So there's a lot of people who do this kind of stuff and a lot of people who are very much willing to help.
It,
Love that. That is a good one. I'm
you
gonna go
gave
to Ed next.
Yeah, you gave like four pearls, and your
Yeah,
last
I
one
know, I
was
know. We're
your
not gonna.
last one was what I had. I mean, I think we're
No,
so
I mean, it's,
yeah, I think we're so lucky with this group. I mean, we've stayed so close and text or talk pretty much every day, and so I think this is one area where it's just so complicated. And having a peer group, a mentor group, a partner, somebody to rely on and run these cases by, and hear other opinions, I think is extremely important. And you mentioned, the learning curve, but I think this is one area where having a group like this and a cohort, people that you can run these cases by, I think can greatly improve your learning curve. And, really, really complicated cases. And that leads you to avoid making the mistakes that others have already made. And there's just so much to learn. I don't think you can do this without having a good support group.
I agree. Mitch.
I think we're always anchored to some lack of progress with the soft tissue. So I would say find, in addition to a good group like I have with these fine gentlemen here, is a plastic surgeon or an orthopedic surgeon who does free tissue transfer. So that person in your hospital is really important for your patients and thus your flow and what you can and cannot do in terms of bone defect reconstruction. So that's the pearl. I will say before I run out of time, Dave, for all of you listening, for all you 7 people listening, we have space for an additional 7 people at the LLRS, Limb Lengthening Reconstruction Society meeting in Montreal this summer, July 2026. Come see us, llrs.org. We're on LinkedIn. We're on all the social media things. And we'd love to meet you and talk about all kinds of stuff, not just trauma reconstruction, but other subspecialties.
Mitch, is this where we show off our cats to the rest of the
Dave, Ed is dying to show his cat.
Oh,
So
yeah.
I mean,
What are you waiting
toss
for?
him a cat question so he can show his cat. Like,
out of here?
not
No.
here. Like, does he experiment with the cats? Does he do like what?
Like after your debridement, you take the bone home for your cat to nibble on.
No, no.
Where's the cat?
They're not in here. They're with my kids. I have kids.
There's no
Kids
editing.
and
Ed.
cats.
We can't
He has
add the
kids
cat
and
They say
later.
that Ed makes the best bone marrow in Western PA.
Well, this has been delightful. Is that a wrap? Or are we still talking? Are we waiting for the
Dave,
cat
you're
to
the
shut up?
moderator.
Oh, we're still going? I thought the
No,
cat was the end of it.
you shut this down. You're the moderator.
Okay. Well, I want to thank my guests, the fellowship class of 2013 from Harborview, currently positioned all around North America, for bringing us their expertise in bone defect management. If this interests you, please come join us in Montreal in July, and we hope you enjoyed listening.